a little bit different today. We're going to try a short presentation followed by a conversation with two guests who I'm very excited have found time in their day to join us. So, Lesley, can you next slide? Sure. Thank you. So Lesley, as I said, is just going to speak for a few minutes to kind of introduce you to the concept of health technology reassessment and some of the lingo that we'll be talking about. And then we're going to have really an open conversation with Dr. Kim Simmonds, who's the Director of Health Evidence and Policy under the Innovations and Strategic Operations branch at Alberta Health. Kim did her PhD here in Community Health Sciences and has since joined the government and really has taken the HTR file on. So she signed on the dotted line for like successful deliverables at Alberta Health. So we're going down together if we go down. And then Dr. Tom Stelfox, who's joined us, who is a professor and the deputy head in the Departments of Critical Care and Medicine. He is also the senior medical director of the Critical Care SCN. He's a double doctor, so a medical doctor and a real doctor with his PhD. And his main research area, in addition to being around the adoption and disinvestment, is really driving patient-centered care through meaningful engagement and partnerships with patients and their families. He has many, many accolades that I could go through, but I just wanted to mention one that's near and dear to my heart. He has mentored over 13 junior faculty, and I consider myself to be very privileged to be one of those people. So thank you both for joining us today, and I look forward to a very lively conversation. We will be taking questions from the room, and then Sarah will also be doing the online management for us. So we welcome those of you online to jump in with your questions throughout the hour.
And just a quick reminder for you three that the mic is right here, so while you're presenting, you can try and speak at it just so that they can hear you more clearly. That would be greatly appreciated.
Great. Okay, so as Fiona said, I'm just going to start off with a brief introduction to this concept of low-value care, and I apologize to those of you online and in the room who've heard me give this introduction before. For those of you who don't know me, my name is Lesley Soril. I'm completing my PhD in Health Services Research here at the U of C under the supervision of Fiona and Tom Noseworthy. Okay, so I think the best way to start off is with the definition, and many of you probably seen this definition before with regards to describing what low-value care is. And I should say that generally in the field, there's no one consensus about how low-value care should be defined. But what I like about this particular definition here is it captures like the essence of some of the conversations that are going on. Oh, sorry. I have two computers going. It captures a lot of the conversations that are going on with regards to low-value care in this space. So the definition, it describes low-value care as an intervention in which evidence suggests it confers no or very little benefit for patients, or the risk of harm exceeds public benefit, and more broadly, the added cost of the interventions do not provide proportional added benefit. So it's really about the net benefit gain, or lack thereof, with regards to low-value care. So with existing health technologies that are used in the system, when they're considered of low value, we often hear this description of them being overused or misused, and even hear the conversation of unnecessary care. And generally, these technologies or health services are not thought to be clinically effective nor cost effective. But it's important to understand that this spectrum of technology value, on the other end, there are also technologies that are considered of high value. And likely as a consequence of overuse of low value care, these high value technologies are often being underused in the system. So these are thought to be very high beneficial, so the benefits exceed the potential risk of harm, and they're thought to be clinically effective and as well as cost effective. Now, broadly for the healthcare system, there are a number of reasons why low value care practices are a major problem. First and foremost, as that definition I provided said, they can be harmful to patients, period. And persistent use of low value care practices goes against or prevents the delivery of high-quality, evidence-based care. Now, when we think of our fixed healthcare budget as well, it's also important to recognize that low-value care wastes scarce healthcare dollars. So there are significant opportunity costs when low-value care practices are in place. And its presence in the system then prevents the creation of headroom for innovation and investments into high-value care practices. So now some of you might be thinking, really, how big is this problem? And many of you have probably seen this infographic already, and Fiona and I have presented it as well at Rounds. It was generated by Kai. Sorry, just too many computers. And this is from work that they did with their administrative data assets across the country back in 2017. And essentially what they found was that for a specific subset of health services, I think it was 8 medical tests and treatments, about 30% of patients may have been receiving low-value care. So annually, they equated this to about 1 million potentially unnecessary tests, treatments, and medical procedures being performed. What's interesting is that internationally, similar analyses have been done in jurisdictions such as the US and Australia, and we're actually seeing really comparable numbers in this 30 to 40% range of low-value care. So, given the breadth of this problem, there are a number of activities that are taking place internationally as well as nationally to address low-value care. In this image, I've essentially dropped a pin into the different regions and countries that have published or have documented accounts of activities to address low-value care. And the green pins kind of indicate countries that have made notable methodological advancements in this area. So from recent reviews and systematic reviews for different approaches and frameworks to addressing low-value care, we've got some examples of methods that have been used in, I guess, most recent years. So the first one in the red, which we refer to as HTA+, this approach typically employs traditional evidence-based HTA processes, so reviews of clinical, economic, social, ethical, legal implications, but this time targeting the use of existing technology in practice versus a new technology being considered for adoption. And it typically results in optimal use type of recommendations, so we hear often these disinvestment type recommendations out of the UK for the technologies that's being evaluated. Second type of approach in the blue here refers to these priority setting activities, and they're often used to determine coverage of health services within a fixed program budget. So one approach that's commonly employed is that of program budget and marginal analysis. So in these processes, typically evidence of clinical and economic evidence are considered together, and then recommendations are made for investment and disinvestment of what to include within a fixed program budget. So you see disinvestment as a kind of corollary to investment with these priority setting activities. And increasingly for countries that are trying to move towards implementing universal health care coverage, we see priority setting activities for their means to figure out what's in and what's out within their coverage envelope or budget. The third type of approach we refer to as list making, and this probably resonates very broadly within the clinical community. With the most widely kind of profiled example is that of the Choosing Wisely initiative. So they have these lists of top 5 or 10 recommendations of things that you should think twice about in the system. And the goal of list making is really to generate lists of unnecessary tests and treatments that should be avoided or not routinely offered in practice. So typically the lists are informed by a combination of evidence sources. So it could be input from clinicians, different consensus-based exercises, as well in some cases reviews of the evidence. And lastly, the fourth type of approach that we see kind of emerging from this literature refers to the implementation of KT and type of interventions. And here we see these taking place to change healthcare practice directly at the front line. So with many of these initiatives, they're often mobilizing recommendations that are coming out of the list-making type of activities, and then employing KT interventions or behavior change techniques to evoke change at the front line with providers. And the goal is then, with low-value care, to de-adopt or de-implement these practices. And locally, we're seeing a lot of great advances in this field, being led by Dr. Stelfox as well as Dr. Niven in the de-adoption space. So collectively, when you think of all these approaches, they've made really great advancements in addressing low-value care in related yet different ways. So our group thought, well, perhaps one way to kind of leverage all these successful opportunities was to kind of merge the concepts and techniques and lessons learned from these different fields and employ them into one single process. And we refer to this kind of omnibus process as health technology reassessment, or HTR. And we defined it here as the structured evidence-based assessment of the medical, economic, social, and ethical impacts the health technology that's currently used in the system to inform its optimal use in comparison to its alternatives. So you can see really parallels to that of HTA, in which it's defined. But with this definition, I think it's important to recognize that the objective of reassessment isn't solely restricted to eliminating or reducing low-value care, but also potentially increasing the use of high-value care technologies as well. Okay. So to operationalize this definition, many of you who've seen me present this figure before, I'm on a roadshow with it. This is the conceptual model that we've used to operationalize reassessment. And it essentially depicts the reassessment process in 6 steps within 3 broad phases. So the first phase involves the technology selection process, so identification and prioritization of candidates which we could reassess. The second phase is the decision phase, so we employ here a lot of the HTA-based processes, reviews of the evidence, and then generation of policy or potential interventions for practice change. And then the third step is the actual action, so implementation of these recommendations, and then having that monitoring and evaluation post-implementation or throughout. Alongside on the arrows here, these depict 2 foundational components for reassessment, the first of which is meaningful stakeholder engagement, and the second is ongoing knowledge exchange and utilization. So we consider these as foundational, and they should run throughout the reassessment process as well. Okay, and my last slide, before we move into the panel discussion, I just wanted to highlight some barriers for reassessment, as well as other activities that are attempting to address low-value care. And these are drawn from the literature, and they come from various qualitative studies that our group has done, as well as other groups in the UK and Australia. And it's been interesting. So these are interviews that were done with often health system leaders who's charged with implementing reassessment activities in the system. And although a lot of these studies is not intentional for the findings to be transferable, we've actually been seeing a lot of commonalities in the barriers identified. So the first of which are challenges engaging necessary stakeholders across multiple levels of the healthcare system. So historically, there's been a lot of activities that are top-down or bottom-up, but not involving everyone throughout. So that's been a challenge. There's also been identified difficulty with kind of identifying and prioritizing low-value care to reassess. So we see with certain leaders, they want to do something, but they don't know how to start. And then thirdly, we've heard a lot, and I think there's a lot of work kind of getting momentum in this area, is that there's often little guidance for methods for implementation. So how can we implement particularly some of these recommendations from list-making initiatives? So with that, I think I'll turn back to Fiona.
Thank you. Thank you. So thank you, Lesley, for that. So while you guys gather your questions here in the room and online, I'll launch us off with a couple of tricky questions, I hope. So I'm going to ask you first, Dr. Stelfox, to a non-clinician, it's a little bit hard for me to understand why would the physician practice low-value care. There are kind of some very public campaigns of choosing wisely out there that I think the clinical community might be at least aware of in their peripheral vision. And so can you talk us through why that happens? Why is this such a pervasive problem? From the bedside, what's going on there?
Right. That's a great question, Fiona. So the first thing I would say is the vast majority of clinicians would never intentionally practice low-value care. There's always going to be in any field someone who's unethical and is selling snake oil, right? And so that's that's a different approach, but that's going to represent a very tiny proportion of probably any community. So then, how do we end up practicing low-value care? Well, I think the key element to that is going to be the fact that is that the clinicians may not perceive the care they're providing to be low value. And so we need to, one, think about how we extrapolate the evidence that's accumulated largely, we'll say largely from randomized controlled trials in experimental conditions, how those are then interpreted by clinicians to implement them in practice, right? Recognizing that many of those studies, the inclusion criteria are fairly restrictive, which then makes their external validity of some uncertainty, right? So clinicians will often say, well, my patient, right, would never fit into that trial. And, I've done this in the past, right, recognizing that for most clinicians, what they're doing is effectively N of 1 experiments, right? The problem is all those N-of-1 experiments is our interpretation of those is limited by our cognitive biases. We don't have a data set that captures all those N-of-1 experiments we've done and go, yeah, every time we've said our patient doesn't fit and we provide this therapy, turns out it worked, or it turns out actually it didn't work and it was a low value care. I think that the conversation will also be different depending on whether the low value is perceived to be something of low risk, right? So it may not have a lot of benefit, but the risk is really low, and so there's a feeling maybe of not a great deal of risk, as compared to something that's quite high risk, and then suddenly the risk of harm may change that dynamic. So I think when there's low risk of harm, there's going to be much more opportunity. Higher risk of harm or serious harm, then that will probably be careful in clinicians' thought process. And so I think one of the ways that would be really nice for us to evolve to, and there's been discussions around this for a long time, but developing learning healthcare systems, where yes, we have our evidence base which informs them, but at the same time, the actual clinical experience is then fed back to clinicians, whatever profession. They can then see how they're practicing, how it might align with the clinical evidence, or whether it's different, what their actual outcomes are. Maybe I'll stop there.
All right, that's great. Thanks, Tom. So Kim, where does age fit into this?
We're the government. We're here to help. It's my new line. So I really think that for the most part, most patients, they care what their clinician thinks, and what their clinician tells them is usually, it's like when you go to a mechanic, if they say you should do this, then they buy into it. And for the most part, when we hear from patients, we hear that they always think more is better, right? And so it becomes a little awkward for us on the government side. The two levers that we typically employ, so it doesn't work for every low value treatment, is policies and funding. So, for example, we tend to use the stick in terms of funding. So we won't pay for you to put someone in a bariatric chamber for things outside of the set clinical conditions that are appropriate, right? So you can't just try it out and see if it might work, because you won't get paid. So that's one of the more stick type of ones that we use. The other thing we do is we try and have policies and work with leadership in AHS to say that this is really important from our perspective, right? Because ultimately all the healthcare dollars flow out of the government. And so the more money that we can redirect out of low value activities means that we can bring new high value things into the system and provide better care, which is ultimately what we're all trying to do. So we try and provide where it's appropriate policies and, high-end leadership saying that this is important to the government and it's also important to you. And I think that Alberta Health Services has done a really good job of trying to find leadership to sort of move this along, in addition to having grassroots activities like through the SCNs where they pick stuff up. But I think it's ultimately really difficult for a clinician in all of the lists and all of the stuff to figure out what to do and not do. So the government carves out one little piece that they can, but I think it's a team effort.
So in that, I heard you refer to a couple of different organizations, AHS, the department, and the government, I guess. Can you just explain a little bit how each of those responsibilities or roles might differ for those organizations?
I'll explain how they should work. So the government of Alberta funds healthcare through your tax dollars, and we set policy and direction. And it's not our intention to get into how things should work within the system, right? So we say, these are the things that we would like you to do. We don't tell you how to do them, which can sometimes be tricky if you're Alberta Health Services, because you have a list of demands from the government, and now you have to figure out how to make that work within this confined budget, right? Which is really quite a difficult task. And their job is to operationalize it. So we might have a policy that says we will no longer fund things that are deemed low value, and then they have to figure out how to make that happen. And at the same time, you have clinicians who aren't they aren't in AHS and they're not in Alberta Health. So the government directly pays them fee for service, but they get their privileges from Alberta Health Services or in Edmonton, additionally Covenant Health. And so it's a weird group of individuals that we all kind of have to realize that we're all working towards the same goal. And then ultimately it's the clinician who makes the decision on whether or not to have that practice behave that way.
I have a question for Dr. Stelfox. Do you have an example of something that was identified as low care and that was discontinued easily? And, or an example, or maybe an example of something that's been identified and has been more difficult? And what you think the difference is in those examples?
Sure, yeah, so let me give 2 examples. The first example would be a medication that came to market probably around the turn of the century called activated protein C. It's a medication used in the context of patients with severe sepsis, large international multi-continent study that suggested that in patients with really bad infections and sepsis that this would save lives, right? And then, there's a little bit of, the study wasn't done perfectly. There's a couple little funny things about it, which were disclosed, but it prompted then a follow-up study which showed that it had no effect. And it's a very expensive medication, followed by a third study in a different pediatric patient population which had no effect. And then that was de-adopted because the company pulled the product off the market. So there's beautiful graphs of the use of activated protein C and then a cliff, right? And so that's an example. And what's interesting is that when you speak to clinicians, many of them still believe that it works, right? And many of them believe that there are subsets of patients that they feel that this medication was well targeted and actually wish that it was available for those very specific circumstances. But the evidence, once again, not supporting that. So that's an example of profound de-adoption, right? So an example of something that's probably more resistant, an example would be, let's say, the use of albumin, which is a blood product, which has been studied in a variety of circumstances for which the evidence for most is really pretty weak. And then in the area I work, using it as a fluid in patients that are, let's say, that got bad infections, pretty convincing evidence that it has no better than basically regular saline, which costs about 50th of it. And yet, when we've audited practices in Alberta, about 1 in 5 patients critically ill in the province get exposed to albumin during their ICU stay. And we currently are running an initiative in the Edmonton ICUs to see if we can reduce it. I've just seen the initial audit data, and some ICUs have cut their use by half. So it's somewhere from like 1 in 2 patients getting it to 1 in 4 patients getting it. So it's better. But another ICU has been pretty resistant to that change. And so why is that? It's I think based on a very strong belief of the individuals prescribing the therapy that it results in meaningful clinical improvement. And one of the things, at least in my area, that we see is that we get to monitor physiology all the time. So we'll do something and we'll see, oh, look at that, the heart rate went down, right? And so we can use therapies that might result in a physiologic change that we can see. That doesn't necessarily translate into them getting better more quickly, living longer, and so forth, right? So that is an additional complexity.
I was just going to say, and both of his examples are with critical care physicians where we have a lot, these are very high functioning individuals who are very up to date on the literature. So just put yourself in the position of being a family doctor where you have hundreds of different conditions that you're treating all the time, to be on top of the literature and to be, that's where it's even more difficult to change practice, because the more general you get, the more difficult it is to stay on top of everything. And so if you've always just prescribed this, then you would just always, I always start doing my pap smears at 16. I just think it's a good idea. And then the data says, like, that's not true. But they've got, 1,000 other things that they're trying to remember, and they just forget. So if it's harder in critical care, you can imagine how difficult it is in all the other groups.
And one thing, no, absolutely, it's a really good point. We operate in a very controlled environment as opposed to in a family doctor's clinic, which is a much less controlled environment. But I also think from a historical perspective, we're thinking about practices in terms of broadly how we care for have been going on for hundreds of years, right? And now in a very short period of time, we have this huge escalating body of literature, and we're trying to direct practice, right? So we run steps back. I'm not saying we should wait for generations to change practice, but we're trying to find a lot more guidance when previously there was no guidance. People just did what they thought was best.
So this works well when we have, evidence, clear-cut evidence, as Lesley was saying, like high quality, strong evidence to define high value versus low value care. But what about in the vast majority of those cases where we have unequivocal evidence and we don't know? What do we do in those cases?
So actually, maybe I'll leave the second part for but I'll just deal with the first part with the high quality evidence, which is that's actually, even that is more complicated because what many of us are recognizing is that the reproducibility of high quality evidence that's published isn't what we would hope for. And the example I'll give is as a clinician, what I really worry about is that we are asking clinicians to adopt or de-adopt therapies based on high quality evidence. And then in a very short period of time, not a decade later, but a year or two later, we're saying, what, actually, turns out that thing we asked you to do probably doesn't work, so you should stop doing it. And you think, why is that bad? Well, potentially bad because, one, maybe we're exposing people to harm or unnecessary therapies. But what really worries me about it is that, as I speak to my colleagues, it disengages them from following the scientific evidence. Because they say to me, Tom, last year you asked us to do this, and this year you're asking us to do this, right? It doesn't matter. The year after that, you're going to tell us something different, right? And so the activated protein C would be an example. In my field of critical care, we've now gone through a series of these during my career where we're providing tight glucose control to patients in the ICU until we realize it's killing people. So now we're not doing it, right? We're providing this fluid until we realize, wait a minute, it's ineffective. And that really disengages clinicians. So even within the context of high quality evidence, and to put a little plug in for Dan Niven here, so he was recently just published in BNC Medicine a study that looked at critical care. So I don't know if I'm field once again to keep it manageable. But basically, in the history of critical care, all the studies have been published in the New England Journal of JAMA or Lancet, right, that have looked at diagnostic or therapeutic interventions. About half of them have had a reproduction attempt of the randomized controlled trial. So that's like 50%. Among the 50% that have had a reproduction attempt, right, about half the time, like it's a little bit concerning, like flipping a coin twice, do we get the same answer, right? So it's around 20% of all those studies that are published in high-impact journals that we ask clinicians to pay attention to change their practice, that we actually have some confidence in. That's actually probably a consistency.
So assuming that the evidence is all over the place, we tend to focus our energy because it is such a KT implementation effort to try and change practice. Like changing practice at all is difficult because people just get entrenched in a way of doing it. Once upon a time when we didn't have seatbelts that we wore all the time, it was a huge change. And now if I go somewhere and there's not a seatbelt, I feel very awkward. Like I can't put this, here I am in the middle of Columbia and I have no seatbelt. You get so used to doing things a set way. So we don't really worry about the unequivocal, like the here and there evidence. We focus on the stuff that is going to do harm, right? And so from the government perspective, the more evidence we get that something might do harm, that's where we actually try and push quite strong and say, this could be bad for your patient by doing this. The unintended consequences.
That's on, I guess, the refunding or the RHTA.
Reassessment.
Sorry, reassessment. But what about when you're trying to adopt practices or promote practices, incentivize practices that do good, like that do have high quality care?
I find those ones
Do you just,
Easier.
are
No.
government just focus, as you say, on the stuff that does harm, or?
No, things that are shiny and new are appealing to everybody, right? So if we offer something shiny and new, and then I can sneak out the ineffective one at the same time, like a bait and switch, like you might do with children, this is essentially what we do, right? So it's all just parenting. So there are a lot of really keen people, right? Like Dr. Stelfox, who would love to try and take up a new thing and would be able to have a group of clinicians behind him to try this new thing that might be innovative and creative. All that stuff that's easier to sell than taking something away that you've always done and you think is good. And it's all about beliefs, which is strange because we talk about evidence-based medicine, but in the end, it all comes down to the patient in front of me and what you believe the evidence says.
Can I just jump in for Trevor's comment? So one thing is, like, I've been thinking a lot, evidence is missing, why aren't we collecting it? Yeah, with its use. So there's a lot of conversation in the evidence space about real world evidence, right? Whatever that is. I think that through collection of observational studies, existing practice, administrative data sets, claims data, we have the opportunity to understand how it's being used and for what indications and its costs. So I think there's space to collect data to inform technologies that may have been introduced in the system without sufficient high quality evidence. So I think that needs to start taking place more as well.
And clinicians need to buy in to
For sure.
RCTs, right? Even if they could buy into using like the cluster randomized control trial or pragmatic trial,
trials.
right? Like there's lots of in the middle where we could meet, but you'll find out a lot of people, they grew up in the age of, if it's an RCT, that must be the way. And then when you look at all the people that are restricted out of it, it's like, show me a patient that comes through your ICU that doesn't have one of these comorbidities that they've excluded, right? So once you talk about evidence, that puts you in a whole new, you end up down the rabbit hole of fighting about evidence, and you completely lose the technology in front of you discussion.
So Lesley mentioned that there's little guidance in terms of methods for implementation when it comes to health technology reassessment. So my question is, what are your thoughts around the whole field of knowledge translation, implementation science, behavior change techniques to help move that dial when it comes to de-adoption, de-implementation? Are there good theories, models, frameworks out there that can really make this happen? And do we have good clinical evidence on what KT interventions would be effective in this field?
Should we start with Lesley and then get to you?
Sure, sounds great.
And then Kim, if you'd like to share, of course.
So yes, I think they're incredibly important. And that last barrier that I mentioned, it's a bit dated, but I think the conversations that are happening, and as I indicated, I think this area of the field is moving forward a lot. There was a recent systematic review that came out on de-implementation strategies, I presented to you. And there's an array of different strategies that can be employed. They work to varying degrees, whether it's for de-implementation or implementation of new interventions. And there's not strong quantitative evidence to say which particular intervention is important. And I strongly feel like everything is context specific. So it's context specific and technology specific. So you're never going to say, like, I personally feel you can't say clinical decision support is going to work always. I think clinical decision support is actually really great. I think provider feedback is really great, but I think it will involve a variety of multimodal components that are tailored to a specific situation to be effective. But I absolutely think they're essential in how we're going to actually promote practice change as an outsider, not a clinician.
Yeah, and so I think the literature is evolving very quickly in the area because it's a relatively newer concept. I mean, I'm not saying technology has been there for a while, but the concepts are relatively more recent. And so I know when Dan Niven's thesis did a scoping review of this, which I don't know, 2 or 3 years old now, I think it was like 40 articles they found, and I suspect that number's probably doubled or tripled or quadrupled since then. And I know that they've updated the research to look at barriers and facilitators to de-adoption. And so I think we're going to see that relatively rapidly unfold. guess the question is, I'm not aware of good empiric data. I would suggest we need different models, and let's say the knowledge action cycle or other types of conceptual approaches. Ganza proposed basically using the KTA type cycle, which I think makes a lot of sense. Who knows, right? I think we're going to see it rapidly evolve. I don't see why I don't know whether conceptually we would think of it differently than adoption. I mean, obviously, I should say, it appears like they behave differently, as Kim has alluded to, right? That while we are slow to adopt new therapies, we are even slower to de-adopt therapies if we feel pretty comfortable should we de-adopt it.
I think the only thing that would be helpful that I've noticed is when patients understand. So it's fine to de-adopt something when you're talking about something a patient isn't expecting. Okay, so one of the ones I always use is the chest x-ray in pre-admission clinic. There's no value of it, you shouldn't do it. Patients will never know. They don't go through pre-admission clinic every week, but they do expect like an annual physical and these kinds of things to be done. And when you have expectations from the patients, that's where we need to have a conversation about and get the patients to understand that if we're doing these things for you that are of no value or low or possibly of harm, then we can't do these other things. And I think we've done a poor job, and I mean we as in everyone and probably the government to some extent, to talk to people and have this honest, frank conversation that there are unintended consequences of doing things, or this just wastes your time, and aren't you busy doing other things like shuttling your kids around to soccer, so I think that we need to engage patients to get them to understand in areas where they would notice, right? They're not going to notice a chest x-ray in pre-admission clinic, so don't worry about that, but they will notice the things that they come to expect.
Jumping off of that, I think the facilitators were here. Is there a systematic rule within the process or within this file more generally for the patient or the public voice?
I thought that's what Choosing Wisely wanted to do when they first came out, was that it was a conversation between you and your patient. There was a poster with too much mustard on a hot dog saying more isn't always better, and I think, remember that. Yeah, no, it was cute. But I think, a poster doesn't change behavior, or at least that's what I think the evidence suggests.
So it's interesting, so there's that survey that was part of the unnecessary test report at a Kai where they say nearly 1 in 10 individuals knew of the Choosing Wisely campaign. So to me, it was not effective at that particular time.
And they don't know what that means and what interventions, but I mean, I think there is a place for patients. We have certainly done a good job using them on rare disease files and other particular patient populations where they have a better understanding of the health system and why we choose to do things the way we do, either adoption or de-adoption. But when you're talking about the broad population, there's probably a role to play. I just not smart enough to figure out exactly what it is.
Tom and I spent a lot of time thinking about that. So.
Yeah, so I'm not certain, to be honest. We have a master's student that's doing a scoping review and cites of public involvement in de-adoption. We know about it. I kind of conceptually think of it as consumer reports. That's how I kind of think the public could potentially, for select issues, there might be some reporting, especially around things that would either be a risk for them or maybe inconvenience them, or if we lived in a system where there was co-pays that they might, financial penalty. I suspect on the broader issue of things, Fiona and I chatted about this quite a bit, that probably most patients are not going to be that interested. They're going to want to delegate that to getting advice from their healthcare team. I think.
Absolutely.
Isn't it a reality though that the government just has failed to provide things? Well, no. There's no infrastructure or incentives to inform the patient about the evidence, about choices, particularly in these contexts where the evidence is equivocal, and patients, some would advocate that the decision should ultimately rest with the patient in terms of their preference for risks of either harms or benefits. And yet, physicians aren't compensated for conducting that kind of counseling. There are no resources available in terms of like patient decision aids or anything like that through Alberta Health Services or Alberta Health. I know there's going to be this magical patient portal that
It's like magical connect care.
yeah, that's going to solve everything. But ultimately, like we're just not built to have an informed patient right now.
I don't know how you could have an informed patient. I often ask my parents.
Well, the state of Washington is doing it right now. They're doing it by incentivizing the use of decision aids and making that part of the physician compensation and reimbursement plan.
So I think, yes, we've done a poor job. And I don't think that belongs to just the government. I mean, I think there's a lot of people who could probably own responsibility, but I'm happy to wear it. It's fine.
No. It's such an easy target.
It's so easy. No, I know the faceless, terrible bureaucrats. They're horrible.
Is that being recorded, you know?
Okay. But I think that there are areas where people have done really well. So I saw a presentation that the Kidney SCN is doing, and they're rolling out with other chronic diseases, where they provide, and I don't know what, like you can Google it, you'll probably find something strange with kidneys, but it's like, basically it's a patient decision support tool that lets them decide how they would like, for people who have chronic kidney disease, what kind of care they want. Because you're right, in the 5 minutes that their nephrologist had in front of them, they couldn't decide if they wanted hemodialysis or what was happening. And then once they went down that, they realized, like, I hate this. I don't want to live like this. So they built this platform. It's super interesting. It says, like, how far would you be willing to travel? Where do you live? Kind of things matter to you. And it's used up all over the world, even though it was just built in Alberta, and now they're going to overlay other stuff to it. Their evidence says that they have reduced people who go on hemodialysis that would then quit right away anyway, and that patients are happier. So with their decisions, right, that they felt like they had the opportunity. So it's also available online. You can print. There's all kinds of neat things, and I think that's a neat way to go. I mean, we can always go with paying physicians more and differently, but unfortunately it's a long, terrible bureaucratic process to change fee schedules, to do all that stuff. So if we can do something outside of that, we have the opportunity to be more innovative and nimble.
I'm just going to ask Tom, and then go to Gail, and then Alden. So Tom, we've heard payment mechanisms, long, painful road. You're at the coal face here, really pushing forward this drive to focus on patient-centered and engage patients and families. Are there other things that we can think about instead of always kind of pulling back to, we don't pay them right to spend time talking to their patients?
Yeah, obviously there isn't a magical boat over there to fix right now. The challenge as well is that we're talking about thousands, if not tens of thousands of practice patterns, right? And so we're not going to create 10,000 decision aids that we're going to somehow hope patients will find and make use of and have to update every couple of years as the evidence evolves. So it's a very complex issue. I sometimes wonder whether it would make sense for our system to provide a bigger and more strong gate in terms of the implementation of new therapies, because that would be one mechanism that would maybe make it more constrained, so that clinicians are not able to access therapies. And we do a fairly good job with pharmaceuticals, certainly not with most technologies and practices or off-label use. But that might also constrain things a little bit and make it a little bit easier to focus attention. And that would be the one thought I have. I think that, when I practice care, and I am practicing care in a constrained environment, meaning that there is only so much resource to provide. The example would be beds in the intensive care unit. And I think all of us are very cognizant about being thoughtful about allocating those for maximum benefit, right? And that can get tricky, but we are generally being very mindful of that. But that I think represents a small component of the healthcare system. Most of the time, most individuals who practice are probably not thinking about stewardship in an important way. They're thinking about the individual in front, which they should be, but they're not thinking about, well, the incremental value of that is like so negligible that I'd be better off using those same resources for the next patient I see. Right? And so if there are ways to do that a little bit, that might help.
Yeah, I don't know what you're.
Yeah, I don't
If
know
I
if
have
I
a question or a comment or a thought, but I do some work at the Health Technology Assessment Unit, which includes talking to patients and clinicians. And I guess I want to go back to something to augment the systematic review of the literature. So what is the clinical evidence? But we also make a point of trying to figure out, well, what is some of that clinical experience knowledge? And also, more and more, also what is the patient experience? I'm thinking part of the challenge with getting people to de-adopt, and I think you nailed it, Tom, is that people sometimes don't trust the evidence because their patients aren't involved in those kinds of trials. So I think, and I have done some reading on this in the past, and I think I remember the name of the author, but I remember now about 10 years ago, a wonderful article coming out, written by a group of authors in the UK, and it was really what counts as evidence-based and patient-centered evidence-based practice. And they had this wonderful model that the patient in the center and the family, and then they had the research evidence, and they had the clinical experience evidence, and the patient and family, like what's the patient's, and generally speaking, patient experience with this technology or type of care, as well as administrative data. So really broadening what we think of when we talk about evidence-based practice or evidence-informed practice. And I've always thought that was really wise. And I think what I struggle with, and maybe would like some thoughts from the panelists on this, well, how do we instrumentally do that? Because I think we need to move sort of upstream and think about how are we judging low-value care? What kind of evidence are we using to make that decision? Because if it's sometimes our high-quality evidence is not enough. It isn't really, and then we run into the problems you talked about, Tom, like then we try and reproduce it. 50% of the time you get a different answer. Like, I think we really need to rethink what counts as evidence when we're trying to determine what's low-value care. But I honestly don't know how we go about it.
I would just jump on top of a moment. I was having a conversation last week with a physician about low-value care, and he interrupted me and said, care is never low value. Services can be higher low value, but care is never low value. And I hadn't thought about that before. And I think he was kind of going back to his roots of what care means. And I don't know if reactions on the panel or that. I don't know, Tom, if you've ever had that kind of knee-jerk reaction to that word either, but the definition.
That's interesting. I haven't, but then I spend most of my time doing research, right? So maybe that's the reason for it. But I can certainly perceive how individuals that are providing care may react negatively if there's a suggestion that the care they're providing is not contributing meaningfully, right? So maybe a way to reframe it is to think about how do we optimize the delivery of care. So whatever is being delivered is providing maximum benefit, right? But the comment's really good. I mean, most of these, what we consider to be high quality evidence, are focused on a primary outcome, right, which we think is important, that we can measure in a reliable and valid fashion, and that we think we can change by studying in thousands of patients. And it's not that that's wrong, but it is one dimension. One of the challenges, I think, with the Choosing Wisely campaign is that those recommendations are largely based on expert opinion, right? And that's not necessarily wrong, but that's maybe one way to bridge the two, is take whatever the available evidence is, and then bring together what's the right group of experts, stakeholders, presumably, to then try and come up with a rational list or ideas of what we should be thinking. You can see my conviction.
I know that.
Yeah.
And just a little bit, one thing I just remembered the author's name. It was Joanne Rycroft Malone, and I think I recall it. So it's quite well cited. It's quite well known in the nursing world. and the patient-family-centered care literature world. But another thing, I was involved with some work with CADIC, where I think we were looking at how they have been involving patients in reviewing for their for new medications, new pharmaceuticals, and they did a review of a bunch of their decisions, and they were looking at the outcomes that were considered in all of the randomized controlled trials that they reviewed, and then they looked at what the submissions they got from patients. And so I guess at that point, there were a lot of outcomes that were really important to patients that are never looked at in randomized controlled trials. So that's another point to consider, right? How do we're never, and some of those kinds of outcomes we're never going to look at in randomized controlled trials. So if we think of that as the only kind of evidence we're going to look at, we're going to miss a bunch of things that are important to people. And I'd say those are, and I think they're important to clinicians who work with their patients too, and they see those. And it often gets at function and what we tend to refer to as quality of life, as opposed to, can you bend your knee 10 more degrees?
Yeah, absolutely. I think there's a value for looking at living longer, value for probably living better, right?
Yeah.
And there's probably also an element of value around being cared for, right? And using it in a very broad way. And we probably are willing to accept different degrees of risk for those, and maybe different degrees of cost.
So we've heard about kind of the poor evidence that can be used, so a single trial not being replicable. And we also know that in some areas, requirements are decreasing for trials, where they want to get treatments in practice as quickly as possible. And a lot of grants actually have an implementation part, so you have to implement as you're doing your research. And so my question is, given the difficulty with de-adoption and how easy it is to adopt, should we be changing the way that we adopt, knowing that if we're wrong, that it's going to be really hard to de-adopt? And how could we, what are the requirements that you might put around adoption, knowing that?
This is a big one for pharmaceuticals right now, right? Where it's a big issue where people want stuff pushed in quickly, and we're always concerned about safety and harm by doing that, and how do you pull other things out? So I was at a talk in another world that I deal with cancer, and they were talking about a new intervention, CAR T cells, and how that's going to come into Canada. But what the conversation was could you try something really new and have Health Canada approve something, but with a time frame where you tested it out basically, and then the evidence had to be collected, all of this evidence and reported in, and then CADIS would essentially do their review, feeding back to Health Canada, aligning for the timeline so that you could theoretically pull it out quickly. It's a great idea, right? I think that's how we should be going, where you could try, fail fast, I think is how Patty words, like do new things and then fail fast and pull it out. I think it would need a culture shift for patients, physicians, all that kind of, like all the healthcare team. But I think that is kind of a way to go, where if we are letting, especially drugs and therapies, come in with less evidence, that we have the ability to pull them out and that everyone's on the same page. If that would really happen, I'd be thrilled.
The only example I know of that is multiple sclerosis in the UK, where they made a deal up front, and then when the data got analyzed, everyone said, okay, it's not right.
Yeah, and so this is the problem.
Just kept doing what,
right, yeah. Yeah, you all fight over how the data was collected, how well it was analyzed, all this kind of stuff, and no one's really a neutral third party to it, right? Everyone's got skin in the game to some extent. But in theory, that sort of value-based procurement is a novel way of doing that sort of thing from the more money government-y side.
The access with evidence.
Yeah, the access with evidence kind of way.
Yeah, no, I agree. I think it's, I think that, so I don't think adoption's easy. I think we've seen that it's difficult, but it does seem to happen more rapidly in de-adoption. And it seems to happen more difficult, probably the more effective a therapy is, right? Like it's almost this paradoxical relationship, right? Where the shinier and less likely something is to actually do anything, the more rapidly it's adopted.
I'm pretty sure that if I buy you a Gaminate, you're just going to want to use it all the time because it's shiny and can I give you some robotic surgery? I've got lots of fun toys for you. But something that's boring, I think, to adopt might not be.
Yeah, so there is this kind of paradox there. It's interesting because, you know, in single-payer systems, theoretically, and I guess Canada's not a great example because we have 13 single-payer systems, right? But if you were to think of single-payer systems, theoretically, you're ideally situated to do that. But obviously, the political nature of healthcare, right, complicates that a lot.
Yeah.
And the fact that we've got very well-organized union structures as well as special interest groups complicates it.
I will say Alberta Health Services is in a good position compared to other provinces in the sense that if we de-adopt a lab test, for example, like vitamin D was one, it is much more difficult to do in systems like Ontario where they have individual hospitals and there's a lab at every hospital because if I don't like what I'm getting in Peterborough, I just drive down to the next little hospital and get what I want. And that is nice for us. I'm not saying we should always use the stick of taking things out, but I do think there are some real advantages to having one system.
We just have 3 minutes left, so I'm just going to ask for any closing reflections or comments from the panel and prompt you in case you don't know where. I'd kind of like to pivot us back towards forward thinking and success. Where would we be in a year for you to say we've had a successful year in this agenda?
A year in government? Wish there was no camera. No, I think success would be that we continue to have buy-in from leadership, but that we also get much more buy-in from the grassroots, right? From the different patients and the clinical team and stuff, so that everyone's swimming in the same direction. But I do feel like we're on our way. But success would be that everyone sort of bought in theory, to what we want to do.
Yeah, I think I would say, I view this as really a quality of care issue. And one of the things that's striking is you have your picture and your figure up of the world, you have to see where those pins are, right? So where are all those pins located? They're all located in high-income countries. Right?
Yeah.
It's always an interesting issue that appropriateness of care is not really relevant in environmental scarcity, right? It becomes something that we focus on once we have an abundance of it, right? So I think the things have changed. I mean, just even during my career, dramatically, I didn't even think of patient safety when I was training. And suddenly it was like, institute medicine important things, the big deal. And the concept of us providing excess care or low value care is really a relatively recent concept for most clinicians, I think. And we're talking about, in our lifetime, big chunks of time, but in the context of medical history, these are tiny snippets. So.
I guess I agree with everything that you both have said. I think broadly, there's places that pieces that need to be put in place across the system. So having providers talking about the fact that there is low value services care, but that exists, and that you have stakeholders through the ministry, through leaders in Alberta Health Services wanting to engage in these types of agendas. I also agree that there needs to be a bit of a paradigm shift with technology adoption and having reassessment as a component immediately after once things are adopted into the system. And I think probably in a year, maybe there will be some more national activities. CADF is rolling out its technology management agenda, so we're looking at optimization of practices and supporting the provinces to do so. And I think, I read the literature a lot, that Alberta, BC, and Ontario, these are also high-performing systems as well, have made great advances. But I think there's still a lot to be learning from the low to middle-income countries. We're doing a workshop at HTAI on the current state of affairs of reassessment, and we're engaging actually stakeholders who participated in activities in low to middle-income countries about how They don't call it reassessment, but their reassessment-like practices have enabled the creation of universal health care coverage for their system. So I think there's lots of lessons to be learned. So having kind of this international increase in the conversation and participation will be winning. And I can stop defining low-value care in a year from now in these talks. I think that'll be a win.
Yeah.
Yeah. No questions online?